Good morning, good afternoon, and good evening, wherever you are in the world. We'd like to welcome you to Rio 2022. My name is Richard Schilling from Welbeck and St Bartholomew's Hospital in London, and welcome to the third edition of Rio. After 2 years of outstanding success, Rhythm Interventions Online aims to be bigger and better than ever this year. We'll again deliver the highest quality CME accredited learning over 3 days of live discussions, presentations and cases. Central to our philosophy is for all sessions to be free for access, providing a platform to ensure the widest possible dissemination of education. It's our aim to have the greatest impact on your success and outcomes to help you, the healthcare professional, deliver the highest quality care, supporting the best patient outcomes. And we'll achieve this by sharing operator tips and tricks, treatment strategies, and opinion insights from some of the world's leading electrophysiologists. Organisers, Radcliffe Cardiology with myself as the course director and my course co-directors, Julian Chun, Devi Nair, Jason Andrade and Roderick Tung have formulated a program that we feel will take us on a fascinating and challenging journey through cardiac rhythm management. We'd like to, of course, thank our industry partners and enable the free-to-access nature of this event, the headline partners, Boston Scientific and Medtronic, and our other partners, Abbott and AtriCure, and supporting partners, Biosense Webster, EBR Systems, and Volta Medical. This is a 3-day event with 4 hours of main program broadcasting each day, as well as symposia. Today, we're going to focus on ablation and occlusion. On Thursday, mapping and imaging, and on Friday, therapy and technology. We have cases here from centers of excellence on both sides of the Atlantic, CB Marcus Krankenhaus Frankfurt, St Bernard's Heart and Vascular Center Arkansas, St Bart's Hospital in London, Centro Cardiologico Milan, the University of Arizona College of Medicine, Phoenix, Arizona, and St Antonius Hospital, Nijmegen. We have a global faculty of over 40 opinion leaders from 12 countries, and you, the global electrophysiology community, have registered to join us in your thousands, with over 5,500 registrants from professionals across the world representing 158 countries. We've carefully curated the program to ensure that there's plenty of value for all healthcare professionals on each day, no matter your interest. The sessions are all CME accredited, so don't forget to request your CME certificate, which you'll find on the left-hand side of the event page. And remember, Rio 2022 is interactive with live polls and audience questions, so please don't forget to submit your questions in the broadcast platform. For the first time, we have the possibility for you to come on screen and ask a question live, so please submit your question and we'll select a few as we go. So please do get involved. Right, without further delay, let's start Rio 2022. So, welcome to day one to this first session of Rhythm Interventions Online 2022. We've got a great session in store. We've got a live case with the title Pulse Field Ablation Using Sedation, the 5S Strategy, which I'm intrigued by, from Boris Schmidt and Julian Chun, CCB Marcus Krankenhaus Frankfurt in Germany. Before we join our case center, I'm delighted to welcome a world-beating, fantastic panel. Jacob Kareth from New York, US, Helmut Purenfellner in Linz, Austria, and Vivek Reddy in New York in the US. Welcome, gentlemen.
Hi.
Hi, Richard.
Hello.
So as with every session in Rio 2022, we are live. So we want you to get involved by submitting questions to us, and we'll address as many of them as we can and potentially bring delegates on screen, maybe one or two. So do get involved. Without further delay, let's hand over to Boris and Julian in Frankfurt.
Good afternoon, everybody. My name is Boris Schmidt, and it's my distinct pleasure to welcome you to the EP Lab in Frankfurt. Together with me for today's live case is, of course, Julian Chun and our team with Silke, our head nurse, Xiaoji Chen, June, and Ramin, who are supporting us. And without any further ado, we would like to start the case. We're a little bit behind time. We haven't prepared a lot. And I would say that when Julian is introducing the case and the patient, I start to do the venous puncture and start the case.
Excellent. So may I have welcome also from my side, and may I have the first slide, please?
I'm going to start.
I would like to introduce today's patient, which we will do and perform the PFA pulmonary vein isolation case. It's a 70-year-old male gentleman. He is suffering, and he's highly symptomatic from paroxysms of atrial fibrillation, and it was classified as ERA 3 to 4. He has no coronary artery disease. He has hypertension, and next one, he has a mildly dilated left atrium, 42 millimeters, left atrial area, 23 square centimeters, and together it is a CHA2DS2-VAS score of 3. And in the meantime, Boris started to perform the venous punctures, and maybe we will show it. Oh, you already did. Okay, we used ultrasound guided puncturing of the groin, and we used 2 venous access to perform the procedure. One will be, it's a short 8 French sheath, which we will use for the coronary sinus catheter. And here comes the SL1 sheath, which we use for the transeptal access. Okay.
CS catheter, please.
Den CS-Katheter hätte ich gerne einmal. Der ist noch nicht da.
Richard, it's okay. Can I just make one quick comment here? And a quick question?
Go ahead.
So I just wanted to highlight the fact that Boris and Julian are using ultrasound. You know, in the Manifest PS registry, where we looked at the complications, the most common complication, and Boris and Julian's team actually was one of the major contributors to this effort, but the single most common complication was actually vascular complications. So I think that using things like ultrasound is very important. And I'm just curious to Julian and to Boris, I know in the US, ultrasound has now become quite prevalent in its utilization for EP procedures. I'm curious, I mean, not that you can speak for all of Europe, but what it's like in Europe, as far as you know.
Yeah, Vivek, thank you very much for this very practical and super relevant point, and very well taken. And I have to admit, we started using ultrasound-guided punctures over the last, I would say, couple of months. Before, we said, okay, maybe we don't need it, so many experience, we did it for many years, and there's no data. And this is why we were not reluctant, but it took a while for us to start a program of ultrasound-guided punctures. And nowadays, we almost switched completely over to it. However, still, recognizing the fact that at least on the evidence-based prospective randomized fashion, the data is very, very poor. And this is why we have some thoughts of how to change that maybe in future. But I fully agree, vascular access, and this is something, of course, we all know is a key point and maybe the major, at least numerically, the major source of complication.
Just, I don't want to interrupt your discussion, just to focus your attention to the X-ray now. We're doing transeptal puncture. It's a single transeptal, and as you can see in this RAO image here, we're preferring a rather central to a little anterior puncture site.
Want me to go over?
So, because the, let's say, the navigability for the right-sided veins using the FARWAVE device is a little better if you have more space to operate. That's why I took this. We have a nice left atrial pressure here. We go over to the left side now, introducing the sheath. So Yeah, I'm sorry to interrupt this discussion around ultrasound, but of course, well, in the US, when you're using ICE for transseptal puncture, I would advise to go central to maybe even a little anterior to have enough space for the septal veins. I don't know if you share this opinion, Vivek and Jacob.
Yeah, I mean,
Yeah,
I think you're pretty well. Oh, sorry. Go ahead, Jacob, please.
Oh, no, I think we're going to say the same thing with these larger one-shot devices. To get into the RIPV especially, you want to have some space. So you want to avoid being very posterior.
Yeah, and I think your point about not being too inferior is also important, because if you're too inferior, again, for that same issue, then you don't have space, at least with this technology, to open up the petals or to really properly position for the right inferior pulmonary vein. So I think your point's well taken.
So as a next step, we're actually performing selective PV angiograms. You can see the right superior vein here in an aerial projection.
Where do you want to go?
Let's move over to the left-sided veins. Should be here, I guess. Yeah.
Boris, do
Left
you
superior.
for any other technology, or is this just for the PFA?
That's our standard approach for all AF ablations. So yeah.
Wait,
Boris, do you use pre-procedural CTs?
No, not on a regular basis. Sometimes patients have imaging before the procedures. The major indication for that is the to rule out coronary artery disease, and we have a protocol that can image both the PVs as well as the coronary arteries, which is, let's say, a one-stop shop technology, but it's not a routine measure that we perform.
Can I ask
Boris, what catheter is that?
It is a multi-purpose catheter, and typically we use 7 French, but nowadays we use, this one actually was a 6F, but typically we use multi-purpose 7 French, no side holes.
Can I ask,
Julian,
Boris,
why
I was
don't you-
curious,
Can I ask the panel?
Why don't we
whether they,
replay
use
the
imaging?
veins and you tell me which device we should use for the ablation?
Okay, let's go in the meantime maybe to the review mode.
Yeah.
Maybe we can show this. Tritt einmal drauf. So now, okay, we replayed here. It's A on the screen A, and I hope you can see it. Yeah, perfect. You have the right upper vein and the aerial 30-degree projection. I will move on to the next selective angiogram, left upper vein, aerial, same angulation. And here we also had the LAO, and you can see it here in the LAO 40. Then he went down, a little posterior rotation in a clockwise fashion to the inferior vein. And here you see the right inferior vein again in an aerial projection. It's like a clockwise sequence which Boris decided on. And now the question would be, as you know, the Therapulse device comes into 31 or into 35 millimeter as its maximum diameter. Vivek, you have a lot of experience with all technologies. What would you suggest to take? Which catheter size, or it doesn't matter?
Well, yeah, no, I think it does matter, and I think your recent paper suggests that it matters a lot. If I won't speak too much about your own data, but you just published a manuscript in Europace. I don't know if it's in press or where it is, but I think it just got
online
published.
Today.
Online today. Oh, wow, quite fresh.
Yeah, online today.
Right. That when you guys looked at those patients that had recurrences, there were 2 observations that I got struck by. Number one, and I've seen this in other cases, that the most common recurrence was related to a gap between the 2 sets of pulmonary vein lesions. So having a gap on the posterior wall. The second observation was that your reconnection rate, which overall was quite good, by the way. The PV reconnection rate in those 25 patients that came back was like, I don't know, 8% or 9%. But it was much higher with the 35 millimeter than the 31 millimeter. And suggesting to me, at least looking at where the reconnections were, that it may be that when you go with a bigger device, that the petals, the way that they sit may sit a little bit further out, which is why you may end up with reconnections on the ridge. So I think based on your own data and looking at the LA size, I would probably go with the smaller one. I guess the one question I had, we looked at those angiograms. I didn't see a marker. Do you just use the CS to tell you distances, or how do you guys decide? Or is it just sort of a gestalt, this looks big, this looks small type of decision in terms of sizes?
Yeah. Maybe you want to answer?
Yeah, I think that's a very good question. Usually, or we could measure the vein diameters.
We did, by the way, many years back.
We did many years back. We can calibrate the system even without a marker. But we haven't done it in a systematic fashion in the beginning of our learning curve. And most of the operators just decided just by the visual impression. And I'm still not sure whether there's a good rule of thumb when you need to decide for one or the other device. That's why we came up with the idea to just prospectively compare the two, 31 versus 35 in a cohort of 100 patients. And actually this guy is also in this study, and we would now randomize him to one or the other device. And at the end of the study, we will find out if there are really true differences between the two catheter sizes for our patients in an unselected fashion.
Should we take this time to randomize now?
Yeah. Can you randomize the patient to a device? What did you do? Okay. But yes, Vivek, of course, you're a very careful reader, and you exactly quoted all the important results of that paper. So durability is extremely high, even in patients with repeat procedures. And the second point is that obviously the isolation with the 31 was better than the one with the 35. However, we did not account for the individual patient characteristics in that observational study.
But what was also interesting was there were more gaps on the left side. Very common, or that was like a common observation comparable to what we also observed with other technologies. So right versus left, more reconnection on the left side.
Yeah. So randomized to 31 millimeters, luckily. And just because not all of the audience know the system, so for navigation and insertion of the FARA-wave catheter into the left atrium, we are using the so-called FARA-drive sheath. It's a unidirectional steerable sheath with an inner diameter of 13.8 French. One, let's say, particular feature of this sheath is that the shaft is transparent. So in case you exchange catheters and air bubbles are introduced, you may easily see them, and careful flushing of the sheath, I think, is of utmost importance for these kind of large bore sheaths. Just to make this comment, I think it's very, very important. Why do I say that? Because in the first 25 cases, when we started our experience, we had 2 strokes that were attributable to air embolism. And that was the time when we, in addition to the FARA-wave catheter, we were using a circular mapping catheter to assess the reliability of the electrograms used for PV isolation. And now you can see the catheter here in my hands. Let me hold it correctly. Where is the camera? Okay, so here it is. You can see Julian is playing with the different poses of the device. Here you can see the flower configuration. It's a pentaspline catheter with 4 electrodes per spline, so 20 in total. From the outermost electrode, you can record electrograms as well as pace the atrium. The other 3 are only there for delivery of the ablation energy, for the pulse field ablation. So this is the flower. And you can change it to a so-called basket or sea urchin configuration like this to get more into the vein, to a more ostial position, and get a, let's say, distal ring of isolation. You can also see that we're navigating the device over the wire. It's a relatively supportive a wire with a J-tip, which is also important in order to avoid perforations. And maybe we can also refer to the manifest experience later on during the discussion. So over the wire, seamless adjustment of different poses for the catheter, 20 electrodes, 5 splines. Okay.
31 millimeter.
Boris, let me
Yes.
come back to your opacifying of the veins. When I saw that visiting you in your lab, I thought, well, that's the idea to go, and then we did it. However, in our experience in my team, we then quit it because of having the CT. And if you have kind of a normal arrangement of the veins, I think you don't need it if you have the CT pre-procedurally. What would you think?
Den RV-Katheter noch.
Well, I do think, Helmut, that you should stick to your standard approach that you're using for AF ablation, for PVI procedures. So I think the catheter is very versatile, and it can accommodate many different anatomies, and so probably it doesn't make a big difference whether you do intraprocedural or pre-procedural imaging. That is my command. The only cases where we really prefer the 35 over the 31 millimeter device is patients with large common trunks. That is really rare, we know, but in those cases we like to do that. So meanwhile, I have introduced the catheter.
Just to add on this point, just a very brief comment. Still, I fully agree with what you said, and also that stick to what you typically do in your daily routine once you're, of course, super experienced. However, the simple PV angiogram tells you a lot of the information. Where is the true takeoff of the vein? It may also help you to ablate really in the target zone.
So maybe now we can switch to the X-ray and the electrograms, if that's possible. Can you do that on both screens? Yeah, perfect. So let me explain the electrograms to you. Of course, we have the surface ECG, 3 leads, and then we have the tracings, the intracardiac tracings called PV. Those are the electrograms recorded from the Fairwave catheter. And on the lower part, we have the coronary sinus recordings. The most distal ones are missing because we connected the catheter to an external pacemaker.
Wir wollten einmal pacen, ne? Sinusrhythmus.
Yeah.
Pre-post.
As you probably know, sometimes patients go into severe bradycardia or even asystole when you ablate, especially at the left-sided pulmonary veins with PFA. And there are 2 strategies to mitigate that. Number 1 is to pre-treat the patients with atropine. And the second, and that's the approach that we prefer, is to put a pacemaker or a catheter into the RV and just pace, demand pacing in the RV with a VVI external pacemaker. Before I put the catheter into the RV, I would like to show you the recordings of the PV, maybe. Let me advance the catheter into the right superior vein. Left superior vein, correct. And now show the tracings, yeah. Can you enlarge the tracings for the audience? Can you make it a little, yeah, that's better. So you see, I think the tracings, the intracardiac electrograms that you see are very similar to what we see with a regular circular mapping catheter. In order to better show you the PV, to discern the PV spike from the far field electrogram, maybe let's pace from the CS. Is that possible? Shaji, can you pace? Just let us show the tracings.
Okay, perfect.
Okay, perfect. So let's keep this on the still screen. I put the catheter into the RV and we are ready to ablate if you like. Or do you want to have more comments?
Just one quick question, Boris. Is there a reason why you like doing the LSPV in an RAO view? Or do you like the LAO view? Or you want to make any comments on that?
Yeah. So diving into or navigating to the LSPV in RAO is our standard because we want to avoid entering the left atrial appendage. And in the RAO view, you usually see the left-sided veins on the left-hand side of the screen and the appendage on the right-hand side of the screen. So we are aiming for a more posterior left-sided position in the RAO. And then as the next step, as soon as if we have entered it, I think it's a very good plane to see the alignment with the axis of the vein. So we try to align our catheter with the axis of the PV to get the most concentric or central position of the catheter. Of course, I agree with you. When using X-ray only, we could or should also move to the LAO position to see that we're not too far in the tubular portion of the PV. However, with pulse field, so far no PV stenoses have been described, so I'm relatively relaxed, I have to say.
All right.
But we can do it. I mean, that's a good point. Let's do it.
Yeah,
Can
the
you
one
show
other
the X-ray
thing.
again.
Sorry, the one other comment I was just going to make is that it's also, if you
That's the LAO.
push the wire deep enough in and you're obviously exit the lung field, then that's also helpful to verify that you're not in the appendage.
Yeah, correct.
Definitely, absolutely right.
So now I think we should have a look to the electrograms.
Shall we first just briefly introduce
How
I can support you during
Okay,
this
yeah,
case?
please, Julian. I hand over to Julian.
I have the great pleasure to just very, very briefly show to you what we do with the console and with the GUI. Maybe we show it one time. We have the signal. We should have the, switch it over. So basically, we started the GUI, and it does not offer too many options.
Oh yeah, there it is.
To let's say manipulate. Now, as a default, we use 2.0 kilovolt as a voltage, and we are basically in the mode to start. It's the preparing. You have to reconfirm, and then the deliver mode or the push button, which I need to push. And down here, you see the number of total deliveries. So, and the idea is to have 4 applications in a basket shape, and then followed by 4 applications with a flower shape, and we always rotate after 2 applications by 30-something degree in order to have and create an overlap of the lesion and the good lesion formation. So this is basically it. And now I'm very happy to support you.
No, please, it's your show. Let's go for. We have the electrograms. That's good. We have Julian there, which is important. We have the GUI and the X-ray. So I think we're ready to start. During the preparation, when the capacitors are charging, you don't see electrograms. Don't get nervous. You hear that sound. That's the charging. And then, okay, give us a. Bradycardia pacing, backup pacing. You see.
Yeah. Did you administer atropine before, Boris?
No, we don't. We have the pacemaker in the RV, as you can see from the X-ray. Okay. And now, after 2 applications in the basket mode, you see 3 splines were looking up. I'm rotating the device a little bit to change my position by 36 degrees. And then we can continue with the ablation.
Can I ask you, to Helmut's question, we have a low threshold for giving atropine at the beginning of the procedure just to forestall the vagal effects. Is there a reason you don't like doing that, Boris and Julian?
Well,
yeah, Julian. Just
we don't do it on a regular basis, Boris said. Typically, in the very beginning, we were interested in how often we see this, let's say, vagal response or bradyal response, and we did count those numbers. That was the major, let's say, reason why we did avoid atropine application before delivery of PFA. In our experience, still at the very end, to administer atropine, even the case was finished and the, let's say, acute response has been diminished, we have not observed any, let's say, longer lasting issues beyond the procedure. This is why we don't do it on a routine basis. And actually, I don't remember a single case in which it was needed.
So now I changed the position to the flower just to.
I just got a couple of questions. So Vivek, firstly, if you give atropine, does that avoid the need for pacing? And then we've got a question for Boris and Julian. How much heparin was given, and what ACT do you aim for?
So very quickly, yes, it does. And, in our experience, and maybe it's different with different technologies and certainly different patients, we have seen some dramatic vagal responses, not in all patients, it's usually the minority. But, if you give the atropine, then, as I had once, I think, joked to Boris and Julian, instead of calling it the 5S strategy, they could call it the 6X strategy and use a single sheath and avoid a pacing catheter. So, yeah, I think that has some advantages.
Boris, I have a question.
Eight applications have been delivered. Shall we just show you the result? You can see now I slide in to the vein in this original configuration. And now it's still pacing in the electrons, but you see that the PV spike has gone, right? There's no more PV spike. Maybe you can show the review screen from the census. Can you show that to the audience? Yeah, you have the nice comparison of the pre and post electrogram at the LSPV. I think that's pretty clear.
Boris, tell us about your anticoagulation strategy.
Yeah. What we do is that before we even puncture the groin, we apply 100 units per kilogram of unfractionated heparin, aiming at an ACT of above 300, rather 350 and below 400. And we measure the ACT on a regular basis. In this particular patient, we applied, we put him on the table a little earlier for the life case, so we applied 12,000 units in the beginning and now another 4,000 during the case. And we're now at 305 with the ACT.
How about the DOACs? Do you stop them before?
Let me see.
Sorry.
Sorry. Yeah. Here we are.
The upper branch. Yes.
That's the upper branch of the inferior. Sorry, I just needed to navigate to the inferior vein.
You want to take a snapshot one time again?
Yeah.
And dive into?
I do. I do the olive, and I will answer your question, Helmut, in a minute. So we take a recording in an olive shape. Maybe that's okay, like this. We have a small spike there. Perfect. Can you? Yeah, that's fine. And then I go to the basket configuration. Start with that one. At the left inferior vein. Let me just check the RAO before we deliver. So again, RAO for the left inferior is a nice angulation to show the orientation of the splines. Okay, let's now ablate.
Boris, can you make a comment about sedation and cough?
Yeah, good point. So first, let's answer Helmut's question. We have the strategy of skipping the morning dose of the NOAC. So it's only minimally interrupted strategy. For the coughing, well, as you can see in this particular case, we don't see any coughing. The sedation is very well with propofol and some fentanyl as an analgesic. But indeed, sometimes we do see coughing, especially during ablation at the left-sided veins. It's very similar, maybe a little pronounced if you compare to the coughing you see with cryo in the thawing phase. But yeah, it can be there. And I don't think that I have completely understood the mechanism.
Again, the vagal response. No?
Yeah.
Does anyone in the panel use ice to position the catheters?
Yeah, I mean, we use ice routinely. So I guess maybe a few minor differences from what Boris is showing. Certainly we use fluoro. It's nice, I think, to know where the wire is because that helps in terms of safety. And then certainly, of course, the transeptal puncture, but also in terms of positioning, understanding the relative location of the catheter to the PV ostia, I think ice is extremely helpful in that manner. So yeah, I think we use ice quite routinely. Most of the U.S. ice is quite prevalently used in AF ablation procedures.
So now the left inferior was treated. You see, again, I'm in. There's no more signal. If you show the electrograms now, please. Yeah. So really silence in the left inferior vein. Let's move on to the right inferior.
We have 1 second. Let us show the right inferior baseline angiogram again to share what you know.
Okay.
Take the reference.
So down there.
The B. Yep.
And one approach, for us, the favorite approach is to open up the catheter to a flower mode. Julian will take back the wire, and then we turn clockwise and bend the sheath a little bit. And now you see how elegantly Julian is diving into the right inferior vein. So
it's amazing.
I really love his hands. And so we have a flower position here. I would keep it that way. I don't dive into the vein anymore. We showed you the way of mapping. Here at the right inferior, I don't want to do this extra maneuver because sometimes you lose your position. But now the live electrograms, you saw it. Okay, nicely done. So we still see far field electrograms, of course, with this large flower configuration.
Very dull signal, huh?
Dull signals.
Yeah. Number 2,
that was number 2. So we had the splines up. So I will rotate the splines a little bit like this. I think that looks good. Okay.
Number 3.
In this LAO view to the right inferior, you really nicely see the petals of the flower.
Number 4.
Beautiful.
If you have sort of rubbish signals, what's your endpoint, guys, if you don't have great signals in the vein as a measure of whether you've isolated?
So usually we have good enough signals to assess PV isolation with the FARAWAVE. So I think the best configuration to make it look like a circular mapping catheter is this olive shape. There's a very nice publication from our friends from Bern, from Tobias Reichling's group, who compared the signals of the FARAWAVE with the signals of a pentaray catheter. And I think the congruence in assessing PV isolation was 98%. So only in 2% of the cases, they deemed a PV isolated when it was not when assessed with the pentaray. So I think it's really, really reliable, and I don't feel that it's really truly necessary to put in a second catheter into the left atrium. That's it, right? For the right inferior?
Yeah, that's it. You want to share?
Let me just make one more comment to that.
Yeah.
Okay, yeah.
So I just want to add to that point, though. Oh, go ahead. I'm sorry. I'll wait till you're done.
They'll just show the electrograms in the olive configuration in the right inferior, yeah.
Can you just real time? Go to real time.
Yeah, and maybe just show real time one more time.
Echtzeit. Einfach auf Echtzeit.
Yeah.
Yes.
Yeah, beautiful. So really nothing, right? Okay, sorry. Yeah, and I move on to the right superior while Vivek is commenting.
You want to go up in the ARIO and LA? What do you want?
I prefer ARIO.
Good, perfect.
Okay.
Yeah, just want to make sure. Okay.
Yeah, I just want to make a comment about the electrograms. No, you're doing the important thing. Look, I just want to make a comment about the electrograms because the reality is, in many, if not most instances, after the first ablation lesion, if you looked carefully, most electrograms will be gone. And I bring that up because, you know, your point about what's the endpoint of the procedure, it's a little bit different, I think, Richard, than in many procedures where with thermal ablation, oftentimes, of course, we want to get isolation, and it sometimes takes time, and of course, you have to assess it. With pulse field, acute isolation happens very easily. I think we just have to remember that acute doesn't translate to chronic. I mean, it never does, but particularly with pulse field. And it really is, I would argue, very important to do whatever protocol you're doing and don't use acute isolation as the endpoint, because if you do, you'll stop after the first lesions, and then all the veins will reconnect.
Can you show the
So I just want to emphasize that issue, that discordance between acute and chronic isolation is even more marked with pulse field if you're not careful.
That's a great point.
While you were talking, just let me show you, we are now at the right superior with the basket. You see the electrograms, and Julian will deliver.
You see it in real time, and
yeah,
we have shown to you the fluoro of the catheter position. And now you may have heard some funny sound. The patient has sort of a phrenic nerve capture, and so we had a hiccup. So this is something which
maybe with the camera, can you show the belly of the patient? This part.
Rotation.
Make it a little larger. My hand, okay. I will just rotate, and then we show you the diaphragm during the next application. Okay, go.
Okay. Shall I go?
Yeah. Look at this. Okay, true movements of the diaphragm, and I will also show you the X-ray now. Yeah, can you, yes, make our picture smaller so we see the X, or move it to the right side so we see the diaphragm moving? Yeah, that's perfect. Are you ready, Julian?
Yeah,
I X-ray, and you see the diaphragm. Boom, 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 boom. Okay, right. This is something important. So with this high voltage, you frequently get diaphragmatic contractions at the right-sided at the right-sided veins. Yeah.
Good.
Boris, are you checking for exit block?
We never do this. No. No, it's not our strategy.
So, Boris or Julian, just remind us what the 5 S's stand for in your strategy.
Yeah, it's simple and safe, single shot, PVI isolation using sedation only.
Last shot.
That was the intent of the study, to do a very streamlined, very simplified approach.
Want to cross-check?
Yeah, for PVI isolation using this new technology. So now this is the olive again of the right superior.
Can you show the electrograms a little bigger?
Yeah, electrograms, and then we're done.
All right.
Boris and Julian, I have a
Still
question.
10 minutes. Yeah.
Boris, Julian, can you hear me?
Jacob, yes. Yes.
Okay.
Perfect.
So my question to you, from my understanding, do you think the improvement that you're seeing with the smaller size catheter has to do with better contact, less dislocations with phrenic stimulation, and maybe a more osteal positioning?
Yeah, it's a good point. In the end, we don't really perfectly know, but the repeat data is at least indicating that the rate of durability is higher with the 31 versus the 35, even though in our preliminary data, it appears not to make a major difference on clinical recurrences still. But yeah, it's a good point. In a very small atrium, of course, navigating a 35 millimeter device may be sometimes a little, let's say, challenging. And therefore, what we did in the very, very beginning, we were very eager because we believed, all right, now we have a 35 device, we use it in every patient. But we had to learn a couple of lessons. And lesson one is, as you pointed out, that navigation may be a little more difficult, and therefore we tend to puncture it a little more centrally or even a little higher and even more anterior compared to what we do with, for instance, RF or with other balloons, where we go posterior inferior with the transeptal. That was one point. And in line with that, of course, is our observation in the 35 using the maneuver Boris did show to you in the flower, rotating nicely over to the right inferior vein is much more challenging. And of course, the contact with the device at the target zone is maybe not ideal. And this could be, I think, a very good explanation, or it could be one reason why there is a difference. But this is at least our, let's say, preliminary thoughts on this.
I would like to add something to Julian's comments, which are all correct. But if you look at the paper carefully, you can see that most of the gaps that we were seeing are located at the so-called Coumadin ridge, at the left-sided veins towards the left atrial appendage, with the 35 millimeter device. And aside from all, let's say, navigation and etc., it could also be that it has something to do with the field density, which is different between the 31 and the 35, I suppose, depending on the configuration that you use. So the further apart the electrodes are when located at the vein, there may be a difference in the density of the field, and maybe then the penetration to the tissue is not good enough. And regarding your comment on contact, just for the audience, you know that, of course, but for the audience, PFA is not depending on contact force. It's just proximity. So I think a field also penetrates tissue if there's no contact, but not deep enough. That's my understanding. Maybe correct me if I'm wrong.
Before we go on to, before we open a bit more of discussion, I just need to interrupt and give you the poll that you've asked us to present. So forgive me. So this is a question for the audience. You've seen the 5S PFA strategy. So what do you consider the major demerit for the simplified 5S PFA strategy? Is it too much fluoro exposure, too little info on the atrial substrate, unreliable PVI assessment, inaccurate positioning of ablation catheter, limited mapping in cases of ATs, or too quick for live cases so that they don't go on for long enough? Vote now, and then we're going to have a look at the results in a minute or two. Sorry, I interrupted you, Vivek. You were going to ask a question.
No, I just wanted to emphasize something, pursuant to Julian's comments about the timing of their experience. I think it highlights the importance of their randomized study that they're doing, because, as you said, you use the 35 more in the beginning and 31 later at the end. There's obviously a change in learnings, just general learnings, transeptal puncture, whatever. So part of that, I think your points are well taken. I still think that your Europace paper is very provocative in that durability, differential durability between devices. But I do hope that in your randomized study, you're going to look at remaps, because I don't know if concern is the right word, but I wonder if we just simply look at recurrence, whether that's too insensitive of an endpoint, at least over, let's say, a 1 year time period, to really see any differences, even if they're real. You know what I'm saying?
Yeah, absolutely right, Vivek. And this is why we also mentioned before that looking into our preliminary, let's say, follow-up data, we don't see a major difference between two arms so far. This is still, we need to have greater numbers and to learn more about the relevance which we find in repeat findings.
So I noticed your closure, Boris. You used a Z suture with a little bit of gauze tied underneath it. Is that right?
That is correct. After having introduced the ultrasound-guided puncture, we feel very confident to just close the puncture site with a C-suture and a little bit of gauze, and we don't even apply pressure tape on top of it. And bed rest is prescribed for like 6 hours. Then the patient can get up and ambulate, and that's very well appreciated by the patients.
And that's not, it's not that tight, that suture.
It's, well, relatively tight, yeah. Just to apply some pressure on the veins. And we don't reverse anticoagulation, by the way.
Let me ask a clinical question, Boris and Julian. When you presented the patient, a 70s, whatever-year-old patient with paroxysmal AFib, symptomatic paroxysmal AFib, and I wonder, you didn't comment on antiarrhythmics, so I presume that they weren't treated with a membrane active agent beforehand. And I'm curious to know what your practice has become now with the advent of pulse field, or maybe even before that for that matter, how you look at first-line ablation in your paroxysmal patients and what you're thinking about any extension to persistence, if at all.
Yeah, very good point again, well taken. The patient was not on membrane-active antiarrhythmics before. He had a strong wish to, even though he was 78 years of age, to have, let's say, an intervention done. And we believe the earlier, the better. And a single shot device may be something very attractive and appealing, of course, in that context. There's cryo data, as you know, out demonstrating the benefit of an early treatment before challenging different antiarrhythmic drugs. And yeah, this is how we see it from a clinical perspective.
I think it will liberalize the indication, right? And I mean, if you now look how fast these cases are going, and if you compare this to the efforts you're taking for just a pure electrical cardioversion, well, the differences are rather small, in my opinion, and probably the differences in treatment effect are very, very large. So I wonder if in the future, immediate ablation as a so-called, or as an emergent treatment for patients entering the the chest pain unit or the arrhythmia unit,
yeah, like a true E-team,
will prevail. Yeah, like an E-team.
Like an E-team, not A-team.
Yeah.
I have a question to you guys. What is your preferred approach in persistent AF using PFA? What do you do?
Well, Helmut, at this point in time, we're still very, very big fans of PVI. And what we go for is a durable PVI with the first procedure in the utmost standardized fashion. So therefore, in a persistent AF patient, even though persistent is, as we all know, very ill-defined, in an index procedure, we would go for a PVI procedure.
Yeah.
Good.
I must say, for someone who does not have access to PFA outside of clinical trials, this case was really smooth and makes me jealous almost.
Thank you.
Yeah, but you know, Jacob, we still have to go with more cases. We have another one scheduled for 8 p.m., so that's why we needed to hurry up a little bit.
Just remind us of the number of applications you give, guys, because we've been asked by the audience how many applications you give per vein.
Yeah, it's a 4x2 recipe per vein, meaning that you do pairs of applications. Basket position number 1 in two applications. You rotate the basket for about 36 degrees. Do another 2 applications. Change to the flower configuration, 2 applications. Rotate again, 2 applications. So that makes it 8 per vein. In total, that's 32. And one application takes 2.5 seconds.
Yeah, and just to add, this is, of course, we followed the recipe suggested and the learning from Vivek, Peter, and others who looked into, let's say, the optimized waveform. And this is the current, let's say, dosing recipe we use. But still, we talked about the more gaps on the left side. One may consider also, of course, doing something else and more on the left side. But there's still a lot of room, of course, for data acquisition, I think, on this.
I think you may have mentioned this, but can you just talk about what your strategy is in terms of discharge, same-day discharge, how you follow up? Have you noticed anything different in terms of your patients after PF versus what you used to do, let's say with cryo or RF?
Yeah, it's a good question. Well, we have economical constraints in Germany, so we discharge patients after 2 nights staying in the hospital. That's only for mostly for reimbursement reasons, and but we have some experience with same-day discharge with PFA cases. They all went well. But like economically, as I said, in Germany, that's not possible to do it in a large scale. Probably Richard has more experience with that. Differences between the technologies, I think some, let's say, operators who use PFA said that their observation was patients have less chest discomfort compared to RF or any other thermal energy. We haven't assessed it in a systematic fashion, so I'm not very sure if that's true. Other than that, it's a very safe procedure. We don't see effusions. We have never seen pericarditis-like symptoms. So yeah, I'm
Just one very short comment on this as well. As a teaser for more to come, we have some data looking into the blanking period and the blanking period recurrences. And it appears that patients who have a recurrence within the blanking period also have a recurrence later on. So the value of at least the classical blanking period is something which does not perfectly work, at least for electroporation, based on our initial experience. Interesting. This is some interesting observation we have.
Yeah, and I think
And when do you
that's
start your
consistent
NOAC, guys?
Oh, sorry. That's fine.
Sorry, when do you start your NOAC again? We've been asked by the audience.
we skip the morning dose, regardless of once daily or BID treatment or drug, and we continue in the evening of the procedure. So we skip only one dose for our procedures.
And a very quick one for the panel. We've been asked, is there any experience and data on PFA on the posterior wall of the LA?
Yeah, I mean, we published a paper a couple of years ago doing in persistent patients doing after PVI posterior wall ablation in the sort of the flat flower configuration that Boris and Julian just showed. And it works quite well. It's relatively quick, relatively simple, sort of making Olympic rings, overlapping rings type of strategy. And the durability was very high. It was basically 100% durable, at least in our experience.
And let me just ask the team to bring up the question that we asked the audience earlier on and see what that result is. So I can see that the main issue is just knowledge about atrial substrate, and that's probably a reflection of the recent excitement about atrial substrate and its relationship to persistent AF and how that might affect outcomes. But obviously we're looking at mainly paroxysmal patients in this technology in this group at the moment. We're coming towards the end of the session, but I'd just like to ask the panel and maybe start with Helmut. Helmut, is this the technology that's going to dominate in the future, or is there still a role for radiofrequency and cryoablation?
Well, I think for paroxysmal atrial fibrillation, in the way that we have this patient here, small atrium, I would think yes. I think this is the way to go for the next years. However, looking at our data recently published in Erase AF, I think there is a role in substrate mapping in persistent atrial fibrillation, because at least for the cohort, within the first year, you will end up with a third of patients having some substrate out of the veins, and you want to know about that. So I think for paroxysmal atrial fibrillation, yes. For persistent, I think there is still a role for mapping and radiofrequency ablation.
And Jacob, your views on that?
Yes, I think very similar in that we know that PVI alone for persistent AF, does not give ideal results. But one could argue that until we have randomized studies telling us what's best, we know that durable PVI just gets us to step one in many of these patients. So I think you'll see a mixture of approaches that just replace PFA with other energy sources that we've been using all along.
And finally to you, Vivek, I'm going to twist the question a little bit and ask you, for paroxysmals, is it just isolation of the veins with the PFA, or do you do anything more than that?
No, I mean, I think it is just isolation. I personally have a low threshold for doing CT isthmus ablation, but I wouldn't open up another catheter for that. So my guess is that, yes, it will be PF for PVI. I have a slightly different perspective, I suppose, with persistent. I think we have to see what the data looks like with PVI and posterior wall, let's say, or maybe not posterior wall, with pulse field, because when you get good durability, we may see success rates that are in the 80% range. If we see that, I personally don't see any role for substrate ablation in the first procedure. I think that the Erase AF study and some of the other studies are very interesting, but if you can do a 30-minute to 60-minute procedure that treats 80% of the patients without additional expense, as well as time, as well as even risk, by the way, by doing other ablations. I would argue you do that, and in the patients that recur, then you do additional mapping or whatever. Look, I think that all these data are interesting. I think that the whole world has changed with pulse field, and many of the trials that we've done, which very important as they are, and I'm not trying to take anything away, but many of them will have to be repeated with sort of an updated, perhaps more durable PV isolation strategy.
Great. Well, at that point, I'd really like to thank Boris and Julian for a fantastic case, and I'd like to thank the panel, Jacob, Helmut, and Vivek, for really keeping us interested and giving some really brilliant insights. Join us in a few minutes for the next session, and we'll see you there.